right, everyone. I have a triple threat. I dumped all this on Mita at the last moment, and she still somehow managed to format it all for 3 different people into one single case presentation form. This was something that I just actually, some patients I just intake Friday and then saw again this morning. So our screening encounter date is somehow wrong. It's in the future, but it's July. So July 9th is what it should say for the screening encounter date. And then I saw them in follow-up this morning. And then there were 3 people, all Caucasian, 1 male, 2 females, and they were all related, although the 21-year-old I'm going to refer to as the son from now on, and the 42-year-old was the mother, and then the 19-year-old is the girlfriend of the son. They all have Medicaid with Aetna. They all work together and they all live together, and they all showed up together on Friday, very, very badly in withdrawal. And so they really just wanted to leave from the moment they showed up and just go use. And so we promised to just do it very quickly and get them into treatment very quickly if they would just wait with us a little bit. And so all my questions today are going to be like, what can we do to shorten the intake process? What is the absolute minimum we have to do before we write a prescription for a controlled substance? And that's sort of what all these questions are going to be asking you guys to think about and guide me on. So the first one I listed was what changes have already occurred maybe with Morgantown and other coach programs with regard to how the induction process runs and procedures. Is multiple and group induction a thing that ever happens anywhere else? We certainly did it on Friday. How has fentanyl changed your dosing at induction? Do you just go in stronger than you used to last year, but before we had fentanyl practically every time? What are the reasons that you would ever say no to Suboxone? Like how much does it, like once you know a person has opioid use disorder, how much time do they need to commit to spending with you, or you're going to just say, come back tomorrow? If they say they only have 5 minutes, I would guess most of you would say, well, you're going to have to come back tomorrow. I can't do everything we needed in 5 minutes, but that's about all they wanted to give me. What is the least amount of information you'd be comfortable covering with a patient if you knew they were in severe withdrawal before letting them go? Would you absolutely have to have a drug screen? Is that a legal requirement? Would you have to have, how much information would you have to give them on informed consent? Would you be okay with skipping all the drug use history stuff that I know Sheena would be very mad if I suggested we should do? It would mess up our GIPRAs. And certainly on the psych and social support questions. So I didn't get into much of these things. So I'll go ahead and jump into the general assessment. We had the 3 people arrive. They did want treatment. They were in withdrawal. And I guess they miscalculated how long they thought they could stay in withdrawal, but it wasn't even 48 hours. It was somewhere into the 16 to 24 hour range that they had last used what they thought was heroin, but we assume is fentanyl because the UDS was negative for all 3. There was no morphine. So the 21-year-old son and his 19-year-old girlfriend, the 42-year-old mother, were all terrible, but I would say the in terms of withdrawal, they were all feeling terrible. But I think the 21-year-old male could barely, even keep his head off the table. He was just sick, feeling horrible. But really, the others were also pretty bad. But I think the 19-year-old girlfriend was the least in withdrawal. She was able to pay attention, but the other 2 had trouble. They just wanted to leave. But they were still agreeable to being seen as long as I kept sort of prodding them and promising, oh, hurry up and finish this. I did kind of, I did get the GIPRA done, or at least a very brief drug use history, which I'll present in the end. And you know, they all report the heroin use. I felt that's enough to say they warrant treatment with Suboxone. I can't do methadone. Vivitrol is not going to be a good choice in this situation. So, but I really didn't talk, but just in a millisecond over the treatment options. I just basically offered Suboxone. I did say that I do have to go over the risks and benefits of treatment before I prescribe it, and sat and talked about how you can't sell it, share it, you got to secure it, and you can't mix it with sedatives. But my risks and benefits discussion was under 3 minutes. It wasn't really a very detailed one. I really focus on the avoid diversion or mixing with sedatives points. The 21-year-old son, he was just out of a Suboxone clinic from 2 weeks prior, where he reported he was kicked out from using fentanyl despite getting 12, that 12 wasn't enough. He wanted 16. I gave him 16 on Friday. I asked the girlfriend, you know, how much she wanted. She didn't know. The son recommended I just start with 8. I tend to start with 8 as a guess anyway. So I gave her that much. And the mother had never taken Suboxone before, but she was saying she used a lot of fentanyl. She was afraid 8 wouldn't be enough, but I still kept her at 8 because that's my standard. This is going to be related back to one of the questions about, well, if you know they're, or at least think strongly that they're using a lot of fentanyl and they want more than 8 on day 1, is WVU doing that? How are you handling that weird fentanyl transition? One thing I do for everyone, I just basically have everyone induce at home, and don't have them sit in the office. There's not a whole lot I can do for them in the office anyway. I don't have like Phenergan injections and Zofran injections available for them if they go into precipitated withdrawal. What I do is I just tell them to take the medicine very slowly at first, maybe just a couple milligrams, and wait as long as you can and before you take it. And that's worked in most cases. For me, I've had most people find that they don't get bad withdrawal with that. On the fentanyl has been my experience. So they all came back this morning. They all said they didn't get any withdrawal with the amount that I gave them, except for the mother. She said that the 8 milligrams not enough, but that it did help, but that she's still spending hours thinking about going and using more heroin over the weekend, but did not. So, so I increased her to 12 and told her to return tomorrow, but I wasn't sure maybe if I should have gone to 16. I think she wanted 16. She also really didn't want to return tomorrow and would have rather had her like a week of medicine, but I wasn't sure on how much to adjust it. So I had her come in a day, and I was just curious everyone's thoughts on that one too, like whether maybe I should have just gone to 16 or gave her a week of 12, or I didn't really know what was the right choice there. But the other two were the son and girlfriend were both very happy with the amount they gave. They said it totally controlled all cravings. Initially, the 8 milligrams had made the girlfriend feel drowsy, but it wasn't making her drowsy. She didn't seem drowsy when I saw her, and she just wanted to stay at 8, so we did that. So I have the individual drug screening and reported drug use histories. So it's going to look like I spent more time on getting all this information, but really it was done very, very quickly by the person that was intaking the patients, and I've just copied everything over for each person. So this is the SUN stuff that we're looking at now, and everything I've gathered. This is all was what was gathered on Friday. So we his incentive for coming to treatment was that he doesn't want to be he's supposed to be in a sober living house and in a treatment program, but he got kicked out and he doesn't want to be taken to jail. He's concerned that the parole officer is still going to take him to jail He has a history of alcohol, but doesn't. He reports he doesn't use it for over a year. His history of multiple overdoses with resuscitations. Still has Suboxone in urine, but and only Suboxone. Very happy about that, but that's because the fentanyl doesn't detect. And he said it had been a week since he last took the Suboxone. It's still in the urine. I didn't list that in the questions, but I am curious, how long would Suboxone stay in the urine? I don't know the answer to that, even though I've been doing this for years. He said he first used marijuana at age 6, and him and his mother got into a brief argument, which I had to de-escalate because she said, "No, you didn't." And so there was this issue of inducing multiple related people that created some real conflicts of interest. But that I still felt better than, sending one home. So we did the group inductions. That all I could get to, and they did all at the very beginning of the group agree to be seen together, so that they just hurry up and get out of there. He did say, well, he de-escalated when he said that, well, I just my first exposure was age 6. I didn't actually start using until later. At first exposure alcohol age 12. I don't know, neither, do we have another case after this?
Dr. Morrison, it's all, the floor is yours the whole hour.
Okay.
We don't have any other cases or didactic.
All right, I wasn't going to go through each individual drug use history if there was time limitation, but it's only 15 after, so I'll go ahead and go through it. He was a very heavy drinker. He reported in the past, including a large bottle of vodka per day. But yeah, again, saying he doesn't like it anymore, and he hasn't done it in a year at this time. He had done some pills of hydrocodone at first at age 18, but had been mostly heroin and meth recently. His roxicodone first exposure reported age 14, most recent use 6 months ago. Benzodiazepines first use age 16, most recent 1 year ago. Crack and cocaine first use 14, most recent 7 years ago. Adderall from ages 6 to 14, but that was only as prescribed, he reported. But he did report meth use from age 14, which was a substance that he really craves and is addicted to and does not use as a ADHD treatment. And he also uses everything IV, and he has had bath salts first at age 14, but not in a long time, over 7 years, as a 1 pack a day smoker. So we'll go to the girlfriend's history that we got. We got a lot less. He did a lot of talking for her. That was also a little uncomfortable. She basically, he would answer her questions, like how much you use, regarding on the heroin. Not very much, not as much as him, as the boyfriend. And she says she doesn't really like meth very much, but has been using it recently. Not sure if she was pregnant, but the test was negative. And prelim urinary drug screen found nothing, but it never does anymore, does it? It's just always all the stuff I'm interested in aren't in ours. We don't get an alcohol test. There's no CLIA wave preliminary ETG testing. There's no testing for gabapentin. There's benzos nowadays. There's actually a bunch of them out there that won't even be detected. Kratom can't be detected. So, but what was weird is usually we do detect meth, and that was not in there. So she said she thought she'd done meth. So who knows what that was? It really was. Her first use of marijuana was age 13. Her most recent use was 4 months ago. Her alcohol first use age 16, but she says she rarely drinks. She's first use hydrocodone age 13. Most recent use 6 months ago. First use heroin age 18. She's only 19. most recent use last night, like along with everyone else, and had all used last night. First use roxycodone, age 13, most recent use 6 months ago, and she did report a use of extensive pill use as a teenager, opioid pills. First use benzos, age 13, most recent use 1 year ago. Started meth at age 19 very recently, and it's only used it a few times, she says. But as we just discussed, it apparently wasn't even meth, so I don't know about that one. And just smokes half a pack a day. And now we'll go to the mother, who's now 42, and she really doesn't talk very much during the session on Friday because she feels so horrible. But she just sort of describes herself as a I use everything for as far back as I can remember person. Starting marijuana at age 13. Opioid pills since a very young age, unclear, but had been 4 years since roxycodone, and had many years of hydrocodone by prescription. Started using heroin at age 33. It's 9 years. Most recent use yesterday, like everyone else. One stamp. She uses IV. They all use IV for practically everything. She reported Xanax use first at age 26, recent 14 months ago. And she actually reports that even though it's been 14 months, that she really loves benzos. She had crack and cocaine use long ago, ecstasy at age 27 just once, Adderall in her 20s, meth at age 13, and regularly using meth long term. And had used bath salts from age 30 to 35. Street Suboxone last year. That actually did not agree with what she told me. But I guess maybe it was the way I asked it. I asked her if she'd ever been in a Suboxone clinic before. So yeah, so that's fine. So she had been exposed to Suboxone a year ago, and smoked half a pack a day. And also very brazenly and impressively, I appreciated that she stated that she has Hep C and Hep B, but HIV negative. All in the last couple of weeks, she had been tested. So, I guess I thought that was really brave because I guess where they're all using IV, I thought that would be something that would be very disturbing to the other two there, that they're all using IV and living together, and that she has these infections. So that's, I think, the whole case. I think we should slide. Yeah, everything else is just, I didn't go into, well, they said, yeah, I didn't do the rest of it because I rushed them out. Even what I got was a miracle. I'm surprised they didn't walk out on me. Is due to very good work by my care management team and this is why care managers is one reason care manager, one of many reasons care managers are vital to treatment, is patients will walk out before you ever get a chance to help if you don't have them there being really supportive throughout the process. So, all right, let's go back to some questions, and feel free to criticize what I've done. There's definitely a lot of things I didn't take care of. I was very limited and time crunched. But I feel like I can be criticized from either side, that I dragged it out too long or that I didn't get enough. And so I'm curious, just how things are going elsewhere, and what you guys would have done in Morgantown in particular. So I guess we'll just start with question one. What do you think are the major changes with regard to induction process with codes in the past couple years?
Hey, Ryan, before we get into that, can we ask some more questions for clarification?
Oh, yes. Yes, please feel free.
How long did it take, that process?
About 45 minutes from the time they walked in the door to the time they walked out. But my process was under 20. what I was involved for all three.
And how long does it usually take?
Well, it's been shrinking rapidly in the last couple of years. That's why I brought it up. But we used to take a long time because we had this giant list of things that OFLAC wants done and documented that it was done on day one. But in the last month, we have really month to 2 months, we have basically said, screw that, and we'll just risk some wrath of OFLAC to make sure people get into treatment. And when they come back, then we'll go through and get all that stuff that's supposed to be documented day one on day two, which we did today. So today they came back in and we spent like an hour with them going through all this stuff and getting all this documentation completed of all the rules of the program and expectations. But the usual, if you were to combine both of those processes, how long does it usually take? If you were to be able to do it all in day one, which I might be able to do if someone came in with no question about what the dose was going to be, and they were comfortable, they weren't with terrible withdrawal. We were just going over all the policies and procedures. We could probably do it really quickly, right? Even the full thing. So I don't know if there is a usual. It feels like there's a lot of variation depending on the patient condition, how long it takes to get through. But I would say 30 minutes to an hour and a half is the sort of the general time it takes to do all that for one person. When you mix it with three, and I usually do them all one at a time to avoid some of the risks. We could be saying an hour and a half. If we tripled it, it'd be an hour and a half to 4.5 hours worth of clinical time to induce 3 people.
Thanks.
Thank you so much, Dr. Morrison. What an interesting case with 3 patients in one. We appreciate it. Did anyone have any other clarifying questions before we get into some of those other questions Dr. Morrison listed? Dr. Baltiera?
Yeah, so Ryan, question about, so you had your team helping you out too. How did they feel about that? I guess, because a lot of times, the medical side's in some ways the easier part. And then the other thing is, I thought my interpretation of OFLAC was that you had to do all that stuff, but it didn't have to be done on the first meeting. I think I can't remember. And again, I've read it, but it always goes in one ear out
Right.
the other.
It has
So
to be
if people-
done. It has to be done at orientation. So what I've done is I've said that this
Within the
is not
first
the
month.
orientation day.
Right. Yeah, and they need a medical evaluation, but again, what does that mean exactly? And so that's where it gets all more on the interpretation. I think you're right.
Right, nice job. I mean, I think you should write write a manuscript, an article, at least to a state journal, because this is I never heard of group inductions concept. This is the first time. I'm not sure about other people here, so this is very interesting. My question is, talking about how much time spent with patients in the first encounter, when patient is in moderate to severe withdrawal, and how much information can we get? How reliable are they? So what is of high priority? What is the highest priority at the time when we see this kind of patient? So I think you did a wonderful job, and they came back and they got a relief after getting your medicine. My question is, how do they get a prescription? Basically, you prescribe the medicine, then they go to a different pharmacy to fill it. How, I don't know how. What is basically how far is the pharmacy from you, or how is it possible to get have a way to work with the pharmacy to get the film right away to your place to do induction?
Yeah, I'm very lucky that I've got a pharmacy literally across the street that's a CVS, and I have another one that works with me directly that's within our FQHC that's 4 blocks up the street that can guarantee that if necessary, the medicine will be written off for the first visit if they're not able to get the insurance stuff through right away.
Yeah. Dr. Zhang, just like, you know, in family medicine, this is what I was joking with Ryan in my comments. He's acting like a family doc. We don't call it a group induction, but a family will come in, and we've done it over COVID on the phone. Husband-wife inductions, you know, and it depends on the situation. You're right. And I agree with you. Patients at this stage are not often, what they tell you isn't very reliable. They aren't very comfortable. You know, they don't trust you. Their drug use seems to grow over the next 2 to 3 visits. All of a sudden they use a lot more than what they told you, you know. And I think that's just part of the process. So I think it's a really good point, Brian. I think writing that would be good, because what's the main goal is, one, to get people in treatment, trusting, and stay alive. That's my perception, you know, and so I don't think you did anything wrong, crazy. I think it's really a good creative way of getting people in treatment. And I think they're, you know, who knows if they'll be successful, but their chances go up by you having prescribed and gotten them into the program, as opposed to one more barrier, come back tomorrow even, which is really good. We've got people with 6 weeks waits. And so our goal is to get people on medication within, if I can, within 24 hours. And, you know, using our emergency departments, we can often do it same day. So yeah, I think that's great. I think that it's a good thought out, you know, model that will trigger ideas.
NIDA funded a lot of projects on initiating Suboxone or buprenorphine related projects.
Dr. Stan, we can't hear you.
Yeah, it's a little muffled and quiet sounding. There might be something covering your mic, maybe.
A coconut, maybe? Is there a coconut covering your mic?
The ocean breeze.
Yeah. Cabana boy.
What happened?
We were able to hear you a little bit before too. I'm not sure, maybe the positioning of the computer, maybe.
Right.
I'm gonna log out and log in.
No, you're good.
Good now?
Yes, I think it might be a
You're
matter.
better.
Just distance.
Yeah.
I'm gonna log in and I'm gonna log off and log in again.
Okay. Sounds good, Dr. Zhang. Laura, did you have a comment also?
Yeah, Ryan, I was just curious. So do you guys send out the urines to test for fentanyl, so you'll know that a little later in the process?
No, I did not.
So that might be something to think about doing. Now, you wouldn't know it that day, and you know it still makes sense to induce them because they certainly look like they're in, or sounds like they're in opioid withdrawal. But just to see, you know, if that is in fact what they were taking, or if nothing shows up on the confirmatory, and try and sort out over time, you know, what exactly they were using.
Oh,
Hey, Dr. Zhang, welcome back.
hear me now? Is it better?
We can hear you. It's still a little distant sounding, but we can hear you.
I apologize. I don't know what happened to my computer because I'm using my home desktop. But anyways, what I'm trying to say is NIDA has funded a lot of projects initiating buprenorphine related products in emergency room. The whole purpose is to give evidence to start treatment and try to increase the retention and also coming for help. I mean, treatment seeking behavior. I think Dr. Morrison's this case series, I mean, this case, I mean, it's case series actually, so 3 cases, 3 patients together. Actually, it's a new model. I think it's a publishable evidence that patients' family can be treated together, can be initiated with MAT and in the one clinic visit. Then hopefully they'll come back, and this is very encouraging.
Well, and remember, Wen Hong, we've been doing it for the last 20 years, just not on an inpatient, outpatient basis. We do it on our dual diagnosis unit all the time.
Is that as a group, James?
Yeah, yeah,
Yeah, so you get them all together. Makes sense. Yeah.
yeah. So we always, in a dual diagnosis unit, we have group rounds in the morning, so we're able to be efficient with everybody, and we're able to start them all at the same time if they need to. So if 10 people came in opiate withdrawal and I'm seeing them in the morning, we can start them all right after I see them.
So another question, are people also starting, I mean, obviously everybody's doing on video, right? I mean now, but are there other models that people are doing like Ryan, starting people like that remotely, or, you know, through outreach programs or just through telephone calls?
There are places to tele-MAT, and they do, in, you know, they, I don't know, somebody probably, in I remember I talked to a company who, from a different state, actually they do tele-MAT, telephone induction, but there was somebody on site to evaluate as well, not a physician, but a physician was providing a medication prescription remotely.
Thank you all so much. And Dr. Morrison, I know you had a list of some of those other questions as well. I'm more than happy to pull up the case and pull up those questions again, and we can maybe go through some of those, but I won't be able to see you all. So just feel free to unmute or chat, everyone. Did anyone have any other feedback about some of these questions here or recommendations for Dr. Morrison?
Just for clarification, it's the COAT program. There's no S in COATS unless you made up something that stands for S in COATS.
It stands for super, because you guys
For
are super.
Gotcha. Okay, we'll take that. But what, you know, it's kind of interesting just as far as anything that's changed in the induction process. Of course, when we first started doing this in 2003, is we did in-house inductions and realized pretty early on that that wasn't necessary. And now we do what you do, of course, which is let people take it home and do it at home. But I don't know if really over the last couple of years we've changed much regarding our induction process, but I'll let any other members of the team correct me if something comes to mind.
I had a, go ahead, sorry. Go, Dr. Hirschler, go ahead.
I was just going to say there is a reason to withhold an induction with Suboxone, and that's if a patient is grossly intoxicated. You know, if a patient is unable to, you know, if they're apparently intoxicated, I would be very nervous about, you know, adding Suboxone to their situation, like with alcohol or sedatives, or so have them come back and try when they're not intoxicated.
Yeah, I second that. There have been a number of occasions over the years where somebody comes in and they are just way too intoxicated, and I tell them that I cannot start this medicine on you. You got to come back tomorrow and look much better than you are now for me to be comfortable starting you on the medicine. And that's probably the only case I haven't started somebody on.
This is Jennifer Boyd from New River. I wanted to clarify something about, I'm a little bit confused about group induction because we routinely bring in between 2 or 3 people who aren't in family groups to go through for induction, to go through the policies and procedures. That all happens as a group. And then they get interviewed about their use history privately. And then I, reiterate the medical end of induction with them as a group. And so is that unique?
Yeah, I think it is.
Interesting.
So I think Jennifer, I sent Ryan a thing, but like Dr. Zhang said, you've got 3 potential models right there. You know, one is kind of doing a group induction for people who don't know what Ryan did, where it's a family member. And then what we've done, which is I've done a husband and wife at a motel that were homeless, done both of them at the same time because that's what needed to be done. And so again, I'm sure people all over the country are doing stuff like that, but just kind of opening people's eyes to, what's possible. I think, Ryan, kind of in terms of the fentanyl, I think I have a lot more people afraid of precipitated withdrawal with fentanyl, whether it's true or not. The patients are much more cautious. They're like, I don't want to do this because I'm going to go into precipitated withdrawal. So I have to spend a lot more time explaining that I don't really think they're going to once they're already in withdrawal, but that's their fear. And so I've been getting a lot of that pushback. And then I think it's hard to gauge because it's how much do people want higher doses. We're trusting them, honestly, by doing home inductions. And I tend to have more people on 12 to 16 milligrams. And my induction is to go up to 12 on day one. And I let them do that and up to, depending on what their use. Again, I'm trusting them. If they're using 2 grams of heroin, which isn't ever heroin, but 4 times a day, they're probably going to end up on 16. That's just, their withdrawal that. And I'm struggling with that because, my, contributing to diversion because we know that, there's a lot of Suboxone out there on the street, but I think it seems like that's what they're needing. So I've been kind of moving pretty quickly to getting people on that. And then again, a lot of people are coming in already on a dose. And do you trust them with what they're telling you? Or do you kind of go, if they go, oh, I take 2 strips. Well, is that where you start or not? I generally have been. Occasionally I'll drop them down to kind of see how they do if I have red flags on certain people. So.
Anybody make a comment on the difference between fentanyl and other mu opioids? Can you hear me? Okay.
Yeah, we can hear you a little bit. So.
My question is basically, my understanding is the fentanyl has higher affinity to the mu receptors comparing with morphine or heroin. We're talking about acetylmorphine. So I guess theoretically, so please correct me if I understand it wrong. So theoretically, precipitated withdrawal is because high affinity of buprenorphine quickly displacing all those weak binding mu 4 mu agonists. So this way patients can have very bad withdrawal because all those kind of receptors kind of emptied quickly and occupied by buprenorphine quickly. So I guess if a drug has high affinity to the mu receptors, it'll be a little bit harder, at least harder, for buprenorphine to replace them. So my question is probably fentanyl. I mean, I have never seen, I'm not sure about any of you here. So I've not seen anybody like, if I start, I mean, they still have fentanyl in urine drug screening just yesterday, but they told me, oh, I used it like, that 2 days ago or yesterday. So if they have already some kind of, mild withdrawal or moderate withdrawal at least. So I start buprenorphine, never had any problem with that. Never had anybody complain about feeling sick. So I'm not sure about your experience. Yeah.
I'm glad you brought that up, Dr. Zhang, because that makes a lot of sense. So you're saying that they should actually have maybe less precipitated withdrawal with fentanyl. The only patient I had one patient, again, it's always hard to tell if it's physiologic or psychologic. I had a patient that relapsed, was using decent amount of fentanyl and getting her back. She had a lot of fear about precipitated withdrawal. I ended up having to put her in the hospital for 3 to 4 days because her nausea, vomiting was so bad. Now, I suspect that may not have all been physiologic. There may have been some other components, in that, but she was pretty sick. And I've never had anybody go through that. So it's really a unique one patient situation. So I don't know if it's, again, psychological versus physiologic. Part of me suspects psychological.
I read
Sorry.
talking about for for anesthesiologists, sometimes patients already have buprenorphine inside of the body. So what they do, if they want to override buprenorphine, the only medicine they can use is sufentanil, which is a cousin of fentanyl. So that means we're talking about, this fentanyl or sufentanil, they have really high affinity. They can compete with, they can fight with buprenorphine. So I'm not sure how easy buprenorphine can precipitate withdrawal. So it's kind of interesting.
We had a patient when I was a fellow over at Center for Hope and Healing who went into very severe precipitated withdrawal. But after repeated questioning, finally admitted to using some fentanyl that he had brought with him like 6 hours before. So that was my only experience.
Also based on, so I'm part of a NIDA study that is, is about 30 sites around the country, inducing people in the EDs. And this seems to vary regionally. So there's although it seems to be creeping west. So this was a major issue in kind of on the East Coast in those sites. And then, I don't know, David, if you've seen a difference, but now it's actually hitting our Berkeley ED where they're having some issues with induction. And it seems to be related to fentanyl. Although I got to tell you, when I look at ED screens with our ED, the vast majority of people are positive for fentanyl who are coming into the ED with substance use related issues. Now, they're not all getting induced on buprenorphine, but there seems to be a regional difference, and that would suggest that there's something different about what's in the substance being used.
Yeah, and I suspect there may be other substances that we're not capturing that may be complicating the factor, and so the withdrawal is just coming off of, cathinones, coming off cathinones potentially. Does that cause, stimulant withdrawal? And so your case, Ryan, where the patient thought they were using meth, they may have been using cathinones because it's a stimulant. That's what we're seeing. People are going, yeah, so we're seeing Coke plus fentanyl usually, or meth plus fentanyl, or cathinones plus fentanyl. And so I wonder, with the polysubstance use that we're seeing, Laura, is that maybe some of the withdrawal that they're going through as well? We don't know. And part of it is we have very rough, it's way better than it was even a year ago, our measures of urine drug screens and all that, but there still could be a lot of stuff that we're not testing for. And so that's why I don't do the rapid dips and as Dr. Berry and Dr. Herschel said, if they're awake and talking to me and look like they got runny nose, itchy eyes, squirming, they get Suboxone, based on their history. So I don't wait for the urine test. It's not that helpful immediately. I think it's helpful to treat their disease, sending out, knowing what they're taking and all that, and to present to them that you don't even know what you're taking. This is dangerous. But yeah.
Agreed. I'll reiterate too what Laura said. I've had colleagues now for a couple of years, primarily on the East Coast, who are seeing and just swear that they're seeing this precipitated withdrawal from fentanyl. And I really do suspect that the product that's being used is somehow a little bit different. Now, it may be polysubstance to some degree, but I suspect that there is a difference in the product that's being used. And I do wonder if we're going to start seeing more of it. There's, one of the conferences I went to a couple of years ago too, with, I think it was Tom Costin, who's one of the big researchers out of Baylor, and he talked about that there seems to be almost some hidden receptors that come out with fentanyl, and I can't remember all of the details, but it was somewhat provocative and intriguing, and just kind of more food for thought.
Well, also, is it true that certain substances at different doses also? Like I heard that kratom, I've seen people at a lower dose, it's a stimulant. As you get higher, it's a depressant, even tramadol. And I know that truck drivers in Africa at lower dose, it's a painkiller. At higher dose, it's a stimulant. And they're using actually to stay awake to drive across countries. And so, there could be maybe a phenomenon like that.
Yeah,
I don't
for
know.
sure.
I don't know if that's true or not, but possibility.
Yep.
Well, thank you all so much. This has been such wonderful discussion. And Dr. Morrison, we appreciate you presenting that case. It really triggered a lot of great conversations here. We do have about 10 minutes left of the session, so I would hate to end it short, but please do continue. Jennifer Boyd, I see you unmuted there.
There was one question that Dr. Morrison asked that I haven't heard answered, which was how long will Suboxone stay in the urine?
Oh, am I unmuted? It should be about anywhere 48 to 72 hours, but usually about 48 hours.
Because its half-life is about 20 to 48 hours, right? Because normally it's like any other drugs, it's about 2 to 3 days, I think. But depends on, I think for heavy users, probably stays longer.
Yeah, and if you send it out and get the metabolites, the norbuprenorphine should be a little bit longer than the buprenorphine.
And not to seem dense, but it was a lot of, this was great, Dr. Morrison, by the way, presentation, but just because there was so much conversation, would somebody take a stab at summarizing what you're saying about what the general consensus is about fentanyl and precipitated withdrawal?
So as a person who's kind of looked at this nationally, I was a disbeliever based on my own experience with our own patient population here, but I'm now sort of a believer both because I've heard this, this isn't just kind of, this isn't a thing that's just happening in one place. It's happening very widespread. And again, it's very easy to capture in the ED when you're having people come in, be induced in front of you and watch what happens. And people really struggle. Some people struggle. There's some theory that it has to do with fentanyl analogs lasting longer in the system. I think we just don't really know, although the CTN 99, which is the study that's being done out of the 30 EDs, is experimenting with inducing people with lower cows, which seems counterintuitive to this. So we're going to see how that plays out, because again, so many people are showing up with fentanyl in their system, and they're actually going to induce with a cow score of 1 or above. The standard is typically 8. And so I think that's part of what we may be discovering. Can we induce people? There's also some evidence to suggest that micro dosing helps with the precipitated withdrawal, but there's no standard protocol for doing that. I know that Dr. Husted has done some of that in our DDU. But I think it's a thing. It's a real thing.
Well, I guess the consensus is people using fentanyl is hard to do inductions, all right? More difficult to do induction. So that's a question people are trying to for now. We don't know whether it's precipitated withdrawal or it's something else, or it's just that they have high tolerance on metabolites. But overall, I think I heard two kind of extremes. Also, I heard people, I read articles about like high dose for the induction.
Yeah, I think I agree with that. I think, if I were going to summarize it, I would say this is that induction on the buprenorphine is probably one of the easiest medical procedures any of us could do, except for 2 caveats. Historically, it was if somebody was on methadone. Then it was a challenge because we had to wait, because methadone is such a long-acting full opioid. We had to wait a lot longer for them to be in withdrawal, because we would precipitate the withdrawal. And so, again, for the last 20 years that we've been doing this or so, usually it's almost a cakewalk to be able to induce somebody onto buprenorphine, unless somebody was on methadone. Then it was a challenge. And now, over the last couple of years, this other caveat with the fentanyl seems to complicate the picture in a number of areas. Not so much here in our state, though I've had it a couple of times occur with some of my patients, not where I witnessed, but where they've told me. And it just requires us to be a little bit more thoughtful than we would have been otherwise.
We are learning from this because on DDU, we have successfully switched patients from high dose of methadone to buprenorphine just within a week. We do microdosing. If you search online, microdosing, methadone microdose, buprenorphine microdosing for methadone. And you will find a lot of case reports. So,
and I'm thinking that's going to be the trick for fentanyl as well, is giving smaller doses of Suboxone more frequently and riding that out to where you kind of have a balance of the receptors, as I suspect is what's going to happen.
Has anybody tried higher doses and suppose the opposite, kind of like overriding that, where your buprenorphine would fill those receptors and take care of that withdrawal or not? I'm just curious, just kind of the opposite effect.
Yeah, that's an interesting thought. The challenge, of course, right, David, is if you give too much Suboxone, just with the Suboxone, even if they weren't on fentanyl, if you give too much, you'll put them in withdrawal because it's the partial agonist. So that's the weird thing. Now, there's a lot of variability even in our colleagues across the country as what they would consider a standard dose of Suboxone. And one of the national studies that we're participating here in Morgantown that Laura's involved with and Dr. Husted is randomizing people to higher doses than what we prescribe typically, because like you all, I usually prescribe 12 milligrams when I'm inducing somebody and will only go up to 16 milligrams. And the state is also, in the insurance in our state too, really limits doses more than that. So it's rare if we ever go above that, but other places are going much higher. But I don't know as far as somebody who's actually starting at, let's say, 32 milligrams of buprenorphine when somebody comes in the emergency department. Ryan, I do think that probably 8 milligrams most of the time is probably not going to be enough these days, unless the girlfriend who's just not using as much.
Mm-hmm.
I figured that was a relic I needed to change from that X waiver training. It feels like almost everything that they say you should do in the X waiver is really not the way to do it anymore. They need to update that.
Yeah, I can't remember if it's ASAM or AAAP has updated and has new materials now.
Thank you all so much. We have a couple minutes left here. So if there were any other comments or questions that anyone wanted to bring up in the last couple of minutes, please do so. Feel free to unmute or chat in. And as always, if there are any resources or materials that you'd like me to distribute in the recap email, just email them either to myself or Elizabeth, and we'll make sure to send that out to everyone as well. But alrighty, so I only have one announcement, and that'll be our next session is on July 26th, and Dr. Hirschler will be talking about modern addictions recovery. So keep an eye out for that email reminder. And thank you again, Dr. Morrison. That was a really great case and really sparked such great discussion. So we appreciate it. We'll see you all next time. Thank you.
Thank you, everyone. Have a great night.
Yeah.